Welcome to the World Institute of Critical Care and Emergency Medicine, a non-profit educational organization built by physicians for physicians with a mission to improve global health care. Our goal is simple: to help healthcare professionals around the world make informed decisions, enhance critical thinking, and excel under pressure, especially in high-stakes, critical, and emergency situations. WICCM offers comprehensive training and resources in critical care and emergency medicine, featuring a core curriculum that covers adult and pediatric care, with courses in pulmonary, cardiovascular, and neurology specialties. From advanced training in emerging techniques to hands-on experiences in critical care, life support, and emergency medicine, our programs are designed to equip you with the skills needed to thrive in demanding environments. Our expert faculty, who offer lectures, mentorship, and innovative insights through annual conferences and webinars. With our online learning platform, you can access courses, workshops, and a rich library of resources from anywhere in the world, making education accessible no matter your location. WICCM also provides certifications and CME credits to support your professional growth and ensure you stay at the forefront of the field. We also foster a global community of healthcare professionals dedicated to advancing the field and improving patient care worldwide, especially in resource-limited settings. Join us at World Institute of Critical Care and Emergency Medicine, where we empower you to make a lasting impact in healthcare.
Hello, everyone, and welcome to our second Fluid webinar. You remember last month, May 19th, we have our first webinar in collaboration between the WICCM and the International Fluid Academy. And today, we are very proud of sharing with you the latest guidelines when it comes to the fluid volume. So this is very successful collaboration, and I'm very happy to show you the latest update clinical practice guidelines in resuscitating critically ill patients. And we are focusing on the volume and the amount of fluid. You remember that the ESICM, the European Society of Intensive Care Medicine, has published 2 new clinical practice guidelines. The first one that we discussed last webinar, it was the type of fluid, crystalloids, colloids, kind of fluid, LR or normal saline or glucose-based solution, blood transfusion, albumin. And today we are going to focus on how much we want to give, mainly in the resuscitation phase and also in the optimization phase. Then we'll be left with the last part, which will be fluid removal in the decongestion or de-escalation phase. So again, a couple months ago, the European Society of Intensive Care Medicine has published the new guidelines regarding the volume. And as you can see here, Dr. Manu invited the first author and second author, Dr. Armand Dessap and Dr. Fayez Alshamsi, and also Dr. Samir, one of the co-authors of these guidelines. So we are inviting one of the most experts in this field today to give you the updated information. Here is our today's webinar agenda. After I'm going to give you a brief intro, Dr. Manu is going to take over, then going to introduce Dr. Fayez and Dr. Samir to briefly give you some background about the methodology and future improvement. Then the main guest speaker and the main talk will be given by Dr. Armand Dessap, who will give overview on the ESICM Part 2 fluid guidelines. Then Dr. Manu Malbrain is going to moderate the session. Then I'm going to give the closing remarks and take home messages. Again, we should understand that resuscitating critically ill patient is very crucial in their outcome, and resuscitation includes 4 phases: initial resuscitation phase, optimization phase, stabilization phase, then decongestion or de-escalation phase. And today we are going to focus mainly on phase 1 and phase 2. I have some questions for you to make this session a little bit interactive for the upcoming couple minutes. I'm going to share with you some questions, and please try to answer these questions in the poll. So my first question is, should 30 ml per kg fluid volume be used for initial resuscitation in patients with septic shock? Just vote for yes or no. Again, this question has been raised by the authors, and they tried to answer these questions in these articles that was published a couple months ago. Just say yes or no. Okay, let's move on to the second question. So the second question is, should a liberal or restrictive strategy be used in the optimization phase of resuscitation in patients with septic shock? We need to move to question number 2. So should we use liberal or restrictive strategy? Again, here we are talking about the optimization phase. Just say yes or no, liberal or restrictive. Okay, let's move on to the third question, which is, should an individualized, personalized approach be used for optimization phase of patients with septic shock during resuscitation? Yes or no? Okay. Let's move on to question number 4. Should a restrictive or liberal strategy be used for patients with hemorrhagic shock? Should we be liberal, give a lot of fluids, or should we be restrictive, giving just small amount of fluids? Here we are talking about all kinds of hemorrhagic shock. Okay, let's move on to question number 5. Should a restrictive or liberal strategy be used for patients with circulatory failure secondary to pulmonary embolism? So if you have a patient with extensive pulmonary embolism and circulatory failure, should you give liberal fluids or restrictive fluid? Should we use which kind of approach, restrictive or liberal? Okay, let's move on. All of these questions, Dr. Armand are going to help us to answer this question during his lecture today. So question number 6, should a restrictive or liberal strategy be used in patients with cardiac tamponade and circulatory shock? So when you resuscitate a patient with cardiac tamponade, do you need to give a lot of fluids or no fluids or very small amount of fluids? Should you be restrictive or liberal? Okay, question number 7. In patients with cardiogenic shock with left-sided heart failure, should we be restrictive or liberal? So try to vote liberal or restrictive. Then the last question for you is, in patients with ARDS, should we be restrictive or liberal in giving fluids for these patients? So just to vote, A for liberal and B for restrictive. Okay, and I will leave you with Dr. Manu Malbrain and our guest speakers today to try to help you to answer this question. Then I will come back to you and also try to verify what we have learned today in the webinar. And I really emphasize that this knowledge that we are delivering and all of these guidelines that we are discussing in our webinars and in our e-learning is with no value except you put it in practice. These are all clinical practice guidelines we need to apply, we need to adopt, we need to implement to be able to improve our standard of care and patient outcome. And the great aim of education is not the education or the knowledge itself, but the action. And with that, I'm going to stop by here and let Dr. Manu to lead the webinar.
Thank you so much, Amr, for this great introduction and for these questions and these polls. Maybe I'm biased, but I think most of the questions I voted restrictive because I think less is more. And I think today we are gonna talk about the dose. And I'm so happy that we are here because it brings back to fluid stewardship. Everyone knows about antibiotic stewardship and the 4Ds, the drug, the dose, duration, de-escalation. So we had the drug during last webinar and last month, and now today we're gonna talk about the dose. So I'm really excited, and it's my pleasure to introduce all 3 speakers and panelists. First, we will have a brief introduction on the methodology, because we all know methodology can be a little bit boring, and it's such a bright weather here in Europe. So Samir Sharif, he will tell us a little bit how all the consensus collection took place. And then we have the main lecture, as already said, by Professor Armand Dessap from France, from Paris. And then we also have Professor Fayez Alshamsi from UAE, who will join on the discussions on methodology, but also maybe the future or things that we should include for the next version of the guidelines. So it's my pleasure to give a first word, a couple of minutes, tell us everything we need to know about the methods of these guidelines. Samir.
Thank you so much. I promise this will be 2 minutes, just to provide a bit of an overview to understand where all of this work came from. So the inception of these guidelines started like several years ago. And one of the first steps was to develop a steering committee. And when they had experts taken from all over the world, not just all over Europe, but folks from North America as well. Fayez and myself are health research methodologists trained at McMaster University. So our expertise is interpreting the evidence, gathering the data, doing statistical analysis on it so that the clinicians and the experts can put things into context. So one of the first steps that we had done, the steering committee had done, was come up with all of the questions that we thought were relevant to clinicians. We then picked outcomes that we thought were patient relevant. So things like mortality, things like post-ICU survivorship. Those are the things that really matter to patients, and that's really what we focused on. And then Fayez and I and members of the committee kind of went into the weeds of things over a year and longer and did a deep systematic review on every single question that we had that we're going to present in the results. And then from those, we screened thousands of articles. We extracted data from loads and loads of randomized controlled trials and some observational data. We did a meta-analysis on them. We took into account the risk of bias, the equity, what's feasible, what's not feasible. And then we deliberated with the experts to say, hey, this is maybe what the paper says, but you have to look at the inclusion criteria. You have to look at the specific methods before you can just interpret the numbers en masse. So it was a lot of work. And with that being said, I'm going to hand it off back to Dr. Malbrain, and then Dr. Armand Dessap will hopefully show you guys all of the results.
Thank you, Samir, for this introduction to the methodology. So it's my pleasure now to introduce Armand, and I had the pleasure also to meet him in person during last meeting. I think it was in Warsaw during the iSpring meeting, where we also had a IFAT mini kind of thing, and this should be an extended version of his lecture in Warsaw. So please, Armand, we are eager to listen and learn from you.
Thank you very much, Manu. I don't know if you can see my slides. So we are going to discuss the amount of fluid and the latest ESICM guidelines that were published recently in intensive care medicine. So here are my conflicts of interest, which are all outside this work. The topic we are going to discuss are all kinds of circulatory failure, or at least the major etiologies of circulatory failure in intensive care unit. So of course, sepsis, but also hemorrhage, obstructive shock, left-sided cardiogenic shock, and also discuss patients having both circulatory failure and ARDS. And we won't discuss everything about the intraoperative setting, which is very specific, the maintenance fluid, which is a very important question, but that has to be treated separately, and also burn management or increased intracranial pressure. So if we start by sepsis, the first question could be, at the initial phase, this is defined by the period where there is no monitoring. What volume should I give to the patient? And you all know that there is a magic number, which is the 30 ml/kilo, which comes from this original report from the Survival Sepsis Campaign in 2016. So they recommended that with a strong recommendation, but a low quality of evidence. And in fact, they are only observational data, indirectly suggesting that, because if in a bundle you suggest to deliver something around 20 or 30 milliliters per kilo, some observational data suggest that the most this target is achieved, maybe the better the prognosis of the patient, but only observational. You can see here also if the fluids are delivered according to that, there is a tendency to have a lower mortality. But in fact, there is no RCT supporting or discouraging the administration of 30 ml per kilo. There have been no study comparing this target to other targets. But we have to acknowledge that in usual practice, these have gained some popularity. And in many trials now, one prerequisite to consider that the patient has received initial fluid loading is to consider that the 30 ml/kilo has been reached. So there is a kind of self-fulfilling prophecy about this number. But if we look more precisely in these trials, we see that the time window in which the authors want the 30 ml/kilo to be delivered is very wide, moving from 1 hour here to 24 hours here. And more importantly, although the mean target is 30 ml/kilo, you can see that the variation and the distribution, the standard deviations are very wide. And although the population may have something which is close to 30 overall, an individual patient may have a very distinct value. On top of that, it should be noticed that high amounts of fluids can be harmful, even at the initial phase. For example, in this famous study by Maitland, the FEAST trial, infants in Africa receiving boluses of either fluid or by saline or albumin versus no bolus had, contrary to the hypothesis of the study, a higher mortality. And this was repeated in adults, also in Africa, where you see that the application of the sepsis protocol resulted in a lower survival as compared to usual care. And in that protocol, the volumes were higher than in usual care. Recently, we performed a meta-analysis with the hypothesis that the setting may be important when discussing the volume and the amount of fluid received during sepsis. And when you separate all the studies dealing with the amount of fluid during sepsis based on the setting, is the study performed in a low or middle income country or performed in a high income country, you see a neutral effect in high income countries. The volume has no effect of mortality, but in low or middle income country, the higher volume is associated with a higher mortality. And one of the reasons, among others, may be the monitoring and the treatment of side effects of higher volumes, for example, the pulmonary effects, because if the studies are divided between those where there is no restriction of access to mechanical ventilation and settings where mechanical ventilation is restricted, the effect is neutral when ventilation is available, but the higher volumes are harmful where ventilation is not available. So overall, we may consider 30 ml/kilo as a maximal target. That was the conclusion of the guidelines in patients with sepsis or septic shock during the initial phase where there is no monitoring. We may administer up to 30 ml/kilo, but considering adjustments based on clinical context and frequent reassessments. So this is a conditional recommendation because, as we saw, there is a very low certainty of evidence, lack of RCTs. It was important to acknowledge that clinicians may choose to administer another target volume based on their clinical judgments, based on individual patient characteristics, based on clinical context. For example, we may consider that when the sepsis has a pulmonary origin, the target may be lower than when the sepsis has an abdominal origin. We may also consider that patients with cardiovascular comorbidities may have a benefit risk which is different and less favorable to higher amounts. And we may consider, on the contrary, that a patient with very important fluid losses, like diarrhea, may benefit from higher volumes. So you see that even in this initial phase without monitoring, the concept of individualizing is there instead of one size fits all with 30 ml per kilo. Second, even when you choose a target, it's important to assess the patient clinically and consider fluid responsiveness if possible. But overall, the initial period is often defined as the lack of monitoring for doing very advanced assessments. So now if we move to the optimization phase where we have a monitoring, the first question is, should we use higher versus lower volumes? Here, the risk of fluid overload, nicely highlighted by Manu in this very nice paper, is very clear. Fluid is a drug. We aim at some efficacy, but we should be cautious about side effects, which can be respiratory, hepatic, gastrointestinal, etc. We know for many years now that there is a robust link between fluid overload and mortality during sepsis in particular and in ICU in general. And studies have compared a globally systematic higher volume approach versus a systematic lower volume approach. Two of these studies are the classic trial with no difference between the two groups, and also the Clover trial with no difference between groups. And there have been many meta-analyses like this one showing that even in subgroups of interest, there is no signal towards one or another strategy, considering that all these trials were made in high-income countries. So the meta-analysis done during the guidelines showed no difference between higher and lower fluid volumes. And we decided not to recommend either strategy, but we did not recommend any of them because of the third question I will discuss now, which is the possibility not only of giving higher volumes to everyone or lower volumes to everyone. We know that there is no difference in high-income countries with that two strategies, but with the question, may we individualize the fluid volume during this optimization phase? And here, we know that there have been many tools developed in recent years, like the fluid challenge, the fact to have a target to stop fluid resuscitation, the fact that we can assess fluid responsiveness. For example, the group by Xavier Monet have worked a lot on this with many proposals, either in patients without mechanical ventilation, like the PLR test, or in patients with mechanical ventilation, with many tests like the tidal volume challenge, the pulse pressure variation, the stroke volume variation. You all know those tests. You all know their limitations, their strengths. And we may even add that we can try to individualize the amount of fluid during the optimization phase based on the phenotype of the patient. You know that there are many works now using either hemodynamic phenotypes, for example, here with echocardiography, considering, for example, that when a patient is hyperkinetic, he's likely hypovolemic, or even more complex phenotypes, like the hyperinflammatory or the hypoinflammatory phenotype described here. And in terms of using all those tools to try to give a specific volume to a specific patient based on his phenotype, they are not RCTs, but there are some observational data showing that individualizing the strategy may favor, may improve the survival of these patients. And also, we found a good signal in terms of renal failure and requirement for renal replacement therapy, with here also the individualizations favoring less use of renal replacement therapy, possibly due to the fact that we have less hypoperfusion and less congestion when we individualize. So the conclusion was that during the optimization phase of septic shock, we suggest an individualized approach as compared to a non-individualized approach. This is a conditional recommendation with very low certainty of evidence because of the lack of randomized control trials. Now, if we move to hemorrhagic shock, here there is a very appealing concept, which is permissive hypotension. We base on the reasoning that if the blood pressure is too high, this will jeopardize the control of the hemorrhage. So there have been many RCTs testing the fact of having lower targets of either systemic blood pressure or mean blood pressure. You see that the classical target of 90 here is lower, more close to 80 for the systolic blood pressure, and the classical target of 65 for the mean blood pressure is lower between 50 and 60. And in these approaches, many of authors use less fluids in order to attain those lower targets. When doing the meta-analysis, we found essentially this huge study by Bickel and other small studies in penetrating trauma, showing that there is a trend towards improved survival with this permissive hypotension approach associated with a restrictive fluid strategy. So we concluded that in hemorrhagic shock after penetrating trauma, we suggest using a restrictive fluid strategy as part of the permissive hypotension approach as compared to a liberal fluid resuscitation strategy prior to definitive hemorrhage control, which is the main goal in these patients with trauma, of course. The remark is important because this recommendation does not apply to the intraoperative management of the patient and does not apply to patients with traumatic brain injury, where obviously the target of the pressure will be different to ensure a proper perfusion of the cerebral area. If we move now to blunt trauma, you see that we have less studies, but we still have a trend towards improved survival with permissive hypotension. So we concluded the same thing, that in blunt trauma, we also suggest restrictive fluid strategy as part of permissive hypotension, but here the certainty is lower than for the penetrating trauma, where we had more studies and more patients. And the last type of trauma, here also we have the same remark concerning the fact that it does not apply to intraoperative management or traumatic brain injury. And the last type of trauma is non-traumatic hemorrhage, and here you see that the confidence interval is less clear here, and in this study with including patients with acute upper gastrointestinal hemorrhage, there was no clear signal of mortality, although the intervention was associated with a better outcome in terms of tissue hypoxia, the lactate levels, and also in terms of hemoglobin levels, probably because the restrictive approach led to less hemodilution. But in non-traumatic hemorrhage, there are also observational studies suggesting that early vasopressor use for permissive hypertension, when they are used at high dose, they can be associated with increased mortality. So the conclusion here was less stringent. we cannot recommend the permissive approach in non-traumatic hemorrhage, but in this situation, the resuscitation in terms of amount of fluid should be guided by hemodynamic and biochemical parameters, taking very importantly into the context of the primary disease and also the aim of controlling the hemorrhage. And in terms of goals here, it is important to remember that the metabolic acidosis, the hypothermia, the platelet counts, and the coagulation factors are important goals in the resuscitation of trauma and in hemorrhage, sorry, and in non-traumatic hemorrhage. We think that these goals should prevail as compared to the permissive approach. Now, if we move to obstructive shock, we discuss the two main types of obstructive shock. First, the pulmonary embolism. There are only 4 human studies assessing the role of the volume of fluid in this situation. The first one included patients in shock due to pulmonary embolism and tested the effect of fluid loading by Merca. And in this study, the response to fluid loading was variable. There was an overall increase in cardiac index, but in fact, this increase in cardiac index was variable and was inversely related to the baseline right ventricular end-diastolic volume index. And some patients with very dilated right ventricles even had a decrease in cardiac index with the fluid loading. And there were 4 other studies in patients with pulmonary embolism, but without shock. And in these studies, the authors tested the decongestion by diuretics. So it is somewhat out of the scope because these guidelines was about patients in circulatory failure. But it's important to note that in these patients without shock, diuretic was well tolerated and had some beneficial effects on some surrogate markers like the shock index, the oxygen requirement, or the plasma creatinine. So the conclusion was that in patients with circulatory failure due to acute pulmonary embolism, fluid should be used with cautious, and the decision should be mainly based on the markers of right heart congestion. It is impossible to list all the potential markers, but in the text of the guidelines, you will see that we suggest some of them, which are very simple. If the PVC is above 10 millimeters of mercury, this is a kind of red flag concerning the administration of fluids. If the size of the right ventricle exceeds that of the left ventricle, or if the vexus is more than grade 1, all those signs should make the physician cautious about the administration, and probably when there are 2 or more signs, fluid administration should be considered as contraindicated. The second situation of obstruction is cardiac tamponade. Here, even less studies, only 3 in humans, one testing the effect of 500 milliliters of saline, then nitroprusside, with no significant change in hemodynamic parameters. And in the 2 others, when administrative saline, there was an increase in the blood pressure and in the cardiac index overall. But when you look precisely at the data, for example, in this study, you see that only half of patients, in fact, increased their cardiac index above the 10% target. And in 1/4, it is unchanged. And in 1/3, the cardiac index even decreases with fluid bolus. So a wide variability of the response. The authors tried to identify the predictors of the increase in cardiac index, and there were 2 predictors: if the patient is hypotensive at baseline, and also if the baseline cardiac index is low. So we see that it is not so obvious that giving fluids will increase the cardiac index in all these patients. I don't have enough time, but it is also true even in low pressure cardiac tamponade. So the panel recommended that in cardiac tamponade, obviously the main goal is the drainage, and wetting the drainage, if you give fluids, this should be done cautiously as only a temporary measure before you can have the drainage, and probably with limited volumes, because only one patient over two will respond and some will even worsen. Now, concerning left-sided cardiogenic shock, there are no study even exploring the responsiveness of these kind of patients. You know that in right-sided cardiogenic shock, we already talked about pulmonary embolism. The other situation is right ventricular infarction, where fluid may be beneficial, but in left-sided cardiogenic shock, there are only expert opinions. When you look at some guidelines like this one, they suggest that fluid challenge may be the first line therapy if there is no overt sign of fluid overload. The problem is that in the majority of patients with left-sided cardiogenic shock, there is some kind of congestion. And if you ask to experts whether fluid challenge, like in this study, should be something to be done, the majority of experts say that it is inappropriate. You see that fluid challenge has the lowest score in terms of recommendation during cardiogenic shock. So our conclusion was that the benefits risk of fluid during cardiogenic shock is probably unfavorable, that fluids are not the primary treatment of left-sided cardiogenic shock, and that if you decide to give some fluid because you have some signs suggesting that there is fluid responsiveness in your patient, it is absolutely necessary to monitor closely the patient for pulmonary edema, which is obviously the main complication that these patients may have. And the last question was about patients having both circulatory failure and ARDS. In fact, there are many studies addressing the question of the amount of fluid during ARDS. The problem of all these studies that you can see here is that they exclude patients in circulatory failure. And most of them are, in fact, focusing on the de-resuscitation phase, which was not the aim of our guidelines. This will be the work of a third guideline. And they only included patients who were stable and in which some diuretics could be given for the resuscitation. So to date, there is no randomized trial in patients having both ARDS and circulatory failure. So despite you see signals towards a favorable effect on mortality, for example, here decreased, or in ventilator free days increased here in these studies, this cannot be applied to patients having circulatory failure and ARDS, but this is related to patients having ARDS but being hemodynamically stable. So we need more work on this, and probably more phenotyping. This study is discussed in the guidelines because it's very interesting. It is a sub-analysis of the FACT study, which assessed the amount of fluid in patients with ARDS and a stable hemodynamics. And you see that, in fact, the effect of a conservative versus liberal strategy depends on the phenotype. In patients having an hyper-inflammatory phenotype, probably that the liberal strategy may be beneficial as compared to the conservative, and there is the contrary in those who are hypo-inflammatory. So this just to introduce the future directions. But weighting all those future works, in patients having both circulatory failure and ARDS, we are to date unable to make any recommendation about the volume of fluid administration. So to wrap up all this, we all just saw that for ARDS and shock, we cannot conclude, but we previously saw that during sepsis, if we divide things in initial phase and optimization phase, we may use the 30 ml/kg like a maximal target during the initial phase, but it's very important to adapt it to the clinical context of the patient. During the optimization phase, neither the systematically liberal or the systematically conservative approaches are good, probably, but we recommend to individualize the patient, especially in terms of fluid responsiveness. During trauma, either blunt or penetrating trauma, it is probably advisable to have a permissive hypotension approach, including a restrictive fluid strategy. And during non-traumatic hemorrhagic shock, guide the volume to some hemodynamic, but also biochemical parameters. We saw that during pulmonary embolism, we should be cautious and we should look at the right heart congestion before giving fluids. And during cardiac tamponade, be cautious also and use it also only as a temporary measure until definitive management can be undertaken. Thank you for your attention.
Thank you so much, Armand, for this nice overview. I think, Amr, we will now present the pre-recorded lecture, and we will take the questions at the end.
Please go ahead and open the QA session for now, because Samir already gave a brief intro about the methodology at the beginning. Then if we have, if we need more details, I think Samir and Fayez would be happy also to share more information about the methodology.
Okay, is fine with me. So I'm
unmute yourself, please, Manu.
Yes, can you hear me now?
Still muted.
No, we can hear you. We can hear you, Manu. Maybe Amr, you're
okay, there are a lot of questions in the chat. I'm scrolling over them. So one of them is regarding this mythical 30 ml per kg within the first 1 to 3 hours. We're not quite sure, but there's probably not one size that fits all. And the sub questions is, okay, you have sepsis, but the patient is known with decompensated heart failure, or the patient also has renal failure, or the patient has liver failure. So Armand, what would be your take home or advice for the 30 ml, one, and secondly, in specific patient conditions?
Yes, very important question. So as we said, even that target of 30 ml can be individualized based on the clinical context. So the example you took is very important. So there is a kind of freedom given based on these guidelines to individualize that to the situation. So I will say concerning the 30 ml, I see it now like not a target to reach, absolutely, but a kind of reminder that, for example, if I reach the target, I should do all my best to move into the optimization phase, to test fluid responsiveness, to individualize things. And the other thing is that I see it like a kind of mean for all patients, but having the freedom of having a very lower target, if a patient, for example, have cardiovascular comorbidities, or a higher target, if you have a patient with Vibrio cholerae, a lot of diarrhea, etc. So many experts wanted just to get rid of the target, to say there is no target. The problem of that is that because we are in the initial phase without any monitoring, so without any advanced tool to really personalize, I think it's still interesting to have an idea of what is the rough value in a mean patient.
Thank you, Armand. And when I hear you, and also during the lecture, maybe we need to clarify something for the delegates. And I saw at some point we had over 500 participants. So when we talk about protocolized care, we sometimes talk about personalized care, or we can talk about individualized care. So we agreed and we voted that individualized is probably the best, but maybe, and then for the methodologists, it would be good to explain the subtle nuances and differences between protocolized, personalized, individualized care. Samir or Fayez, do you want to tackle that?
Yeah, thanks, Manu. Actually, before we even tackle that, I just wanted to highlight from a methods perspective, where does that number 30 cc's per kilo come from, right? It's a number that's been cited specifically in the last 12 to 15 years, but it wasn't there before. So what happened 12 to 15 years ago was they did 3 trials, Process, Promise, and Arise, which was a follow-up to Emmanuel Rivers' trial looking at early goal-directed therapy. And so that wasn't a number that they picked out at random. What happened was in all 3 trials, when they had done them, when they looked back, on average, most patients got 30 cc's per kilo. So it's not a magic number. It's just what the evidence has, and there's certainly what is targeted. So it brings back to Armand's point where an individualized approach may be better. And I'm looking at a lot of questions on the chat. So if you're looking at a protocolized approach, you're treating everyone the same. And that has its drawbacks. It might be good at an institutional level where you're standardizing practice, but where it may falter is certain patients may need more and certain patients may need less. That was one of the criticisms of one of our colleagues' trials. I believe it was the classic trial where the mortality was quite a bit higher. And so the thought there was that people in the restrictive arm perhaps needed more fluid and the people in the liberal arm perhaps needed less. And that was one of the big drivers of what Armand was saying, what the experts were saying of perhaps an individualized approach is better. Now, what parameters do you want to use? There's no magic test, a bedside test or anything. You have to use a bunch of things. You might have to use ultrasound. I'm seeing a lot of VEXUS, and Andromeda Shock is going to come out. Andromeda Shock VEXUS is going to come out. That'll provide some more answers. So you kind of have to look at everything. That's generally been my interpretation of the evidence. Fayez, I don't know if you feel any differently.
No, I completely agree with you. It's you will have to reassess, and that's what Armand has said. As part of the recommendation was we encourage re-evaluation after whatever intervention you do, and you can look at many things: the heart rate, the capillary refill, the lactate, the urine output, and these things. And this was deliberated heavily during the guideline development process.
So if I understood well, protocolized, everyone the same, like say a map of 65, 30 mLs for everyone. Personalized could be patient is no with arterial hypertension, so we give him a map of 75, but for the rest, everything the same. And individualized really is on day 1, maybe we have 65. On day 2, maybe we look at the lung water, and we may support other organs, probably treat the organ that carries the highest risk for killing our patient. And this is dynamic and may change, so we need to individualize our treatment. Then there are some questions regarding type of fluids. I know that's about the drug was the first part of the webinar, but maybe colloids. What about colloids? Is it true that if I would give albumin 20%, I can reduce the dose or the amount of fluids maybe by 5, a factor 5, or is it a factor 2? Or did we get any information on that from the literature? I don't know, Armand, do you want to tackle that? Because colloids maybe could limit the dose, and I heard that for most of the conditions, restrictive is as good as liberal, so less is more, looks to me. If we treat fluids as a drug, you're not giving antibiotics for 10 days if 5 days will do the job. So why don't we, why aren't the guidelines more pronounced in stating that less is more and restrictive should be the way to go? Don't give fluids when they are not needed.
Yes, but we wanted to test less of the same thing because I'm not sure that less of different thing is more. If you give another fluid, the price is different, the properties are different, toxicity is different. So I'm not sure that there is evidence that reducing only for reducing is better. And for example, I'm not sure that for the same target, giving less colloids versus more crystalloids is better. The evidence is that it's probably the same.
I'm trying to play the devil's advocate a
I see.
little bit, but what about albumin? Can we make any statement on that? If I would give 1 liter of albumin fluid, would it really matter with regard to the dose to get the same effect on stroke volume or perfusion or cardiac output? Because I think sometimes we may believe that giving albumin will achieve the same results on increasing stroke volume with lesser volume, so that you would not have, and this is part 3, webinar 3, the problems of fluid accumulation syndrome. But I learned from some studies like Robert Hahn, who does some physiology studies, that the ratio is not 1 in 5, it may be 1 in 1.3 or 1.4.
Yeah, absolutely. And on top of that, all fluids have transient effects. So even though you get more effects, that increased effect is also transient. So I think now the question of albumin, but that was more the first guidelines, is in which patient albumin could be more useful. And you all know that probably in cirrhotic patients, etc., there may be a room for this kind of strategy.
And if I may say, Manu, to answer your question, I cite this, I wrote this recently. I agree with you. Initially, it was thought 1 to 3 ratio kind of the albumin, but in the SAFE trial, actually, it was more closer to 1 to 1.2 to 1.6. So it's less than what theoretically everyone was, and that was the 4% albumin, as you know, not the hyperoncotic 20% albumin.
Very nice. Manu, I just have a quick comment here, because I think we need to take advantage on Dr. Ashraf Tayyar presence here, who is an expert in the point-of-care ultrasound in critical ill patients. And he's also our program director for the BOCUS Fellowship. And I would just, want to ask him about most of the guidelines when they talk about the initial resuscitation phase, first 3 hours or so, they don't really mention the BOCUS and the hemodynamic monitoring, But what is the best time? Is it, the earliest is better? Do we really need to wait for initial resuscitation, then in the optimization or stabilization phase, we can use the BOCUS?
Yeah, thank you very much, Dr. Amr, for this very, very nice question, which is really, you're touching a very sensitive point. People, they're looking for magic or near accurate method to assess if their patient is going to respond to fluid. And not only that, but also, are they going to be tolerant to IV fluid, not getting complications? In my belief, which is based on both of literature support and bedside experience, the ultrasound, the point-of-care ultrasonography, is the best way to look at the central circulation station, which is the heart, and the main pipe of the body, which is the IVC, and if possible, the superior vena cava. Not only that, but also to see if your patient's organs is going to tolerate this. Are they congested or not? And tell me what else can tell you if this left ventricle and right ventricle are small enough to receive fluid and tolerate fluid or not. And if this lung, even if the patient looks by history, physical examination, capillary refill, lactate, they are fulfilling criteria to give fluid, but they are very congested. If they give them more fluid, they will go into more congestion. And this is behind the idea why the positive fluid balance make the mortality more. In very short term, people, they miss to know or they forget that septic cardiomyopathy, for example, is in around 40 to 50% of septic shock patient presentation, not a complication after a day or two, but within very first few hours, in 2 to 4 hours, around 18% of patients, regardless of their comorbidity, they develop cardiomyopathy, septic cardiomyopathy, which might involve both in equal percentage, RV and LV. And people also, they forget that in a patient like an ERDS, if they are in high positive pressure ventilation setting and their heart is right side is compromised by the sepsis, compromised by the high PEEP, by the recruitment maneuver, and now they are shocked and we believe that they need fluid. They might have, by the way, pulse pressure variation very high, not because of the fluid, but because of the RV dysfunction or failure. We know from the point of care ultrasonography science and bedside management every day that presence of septal dyskinesia is considered to be absolute contraindication to give IV fluid. Because if you give IV fluid to RV, which is failing RV, you're going to reduce further the cardiac output. You make them more hypoxic and more shocked. So there is no other alternative to use, in my belief, to use. There are supportive other patient is at the end of the day is a lot of puzzles. You put them together, but one of the major puzzle that everyone working in critical care has to know is bedside point of care ultrasonography. And doing the study, prioritize it to be as early as possible, because the more you delay doing ultrasound examination of heart and circulation and other organs, the more you may jeopardize the patient care. This is just in short. Thank you very much for giving me this opportunity.
Thank you, Ashraf, for these insights. And that was exactly my next question. If you could pick one variable, what would be the best to advise at the bedside? Because we're talking about dose, so it's about volume. So we need to know what is the fluid status. Is it low? Is it normal? Is it high? And how much of a volume should we give? And how do other things interfere, like ventilator settings? If I play with a ventilator, I can make basically everyone fluid responsive. If I adapt and go for lung protective, then this disappears. I'm personally biased, and I think it should be intra-abdominal pressure, because it will also affect what you will see on your point of care ultrasound when it comes to IVC scanning and so forth. So Armand, Fayez, Samir, could you tell us what is your most favorite, like it may be a target, it may be a safety limit, a parameter that we can use at the bedside. And don't forget, we have many low middle income participants. So what can we use on a clinical basis? Armand, you first.
So using echo?
No, it could be echo. So I think Ashraf very nicely made the case for point of care ultrasound, which I agree.
Anyway, I'm an echo guy, so so I will stay on echo. So my approach of echo is that there is no magic parameter, and that the beauty of echo is that you can combine many parameters. It's very close to the clinical acumen, and have an idea that, okay, globally, this patient is hypovolemic, or globally, this patient is hypoxic. So you know that we usually use the vena cava, the inferior, where when the patient is not on the mechanical ventilation, and you can also use the superior vena cava if you are doing a TEE. That we give a sense of preload responsiveness, but that parameter is not very robust. In fact, when you look at the raw curves, it's like the delta PP. But if you add to that some information on the left ventricle, you see hyperkinetic. If you add to that the pressure within the left atrium with the mitral flow, you start to have a global picture of a patient which is either on one side or on the other side. So that's why how I teach it to the residents. Don't stick to one parameter and struggle to see if I'm above the threshold or below the threshold. But when you have it up, add another parameter and so on. And lastly, with echo, you as nicely said, you can also look at the other side, not the efficacy, but the tolerance. You can have a drug which is very efficient, but which is contraindicated. So looking at the B lines, etc., is also very important to make the choice of the risk-benefit ratio.
Okay, thank you. So we have two for ultrasound. Fayez?
Well, Samir, can you go first? I mean, I would. I'm not like I'm not trained like Armand and echo, and Samir is an emergency physician. I guess I use echo more, but we use echo more and more, and we do. So I would choose echo as well.
And Samir, are you gonna help me into CVP? Maybe revival of CVP?
Yeah, so I think it's a good question, with or without ultrasound, because some places don't have it. So there's a few things you can do. I think there's some data on cap refill. I think CVP in the right instance can be helpful, not in someone who has AFib, and it depends only on the right-sided pressure, right? Not the left-sided pressure. An alternative you can use is pulse pressure variation. If you have a blood pressure cuff and you have a pulse pressure variation greater than 12 or 13, then perhaps your patient may benefit from fluid. That's something really easy anybody can do at the bedside, and as a surrogate marker if you don't have an arterial line. So I think those things also help. Much like Armand, if we were to flip back to places that do have an ultrasound, it takes about 5 minutes or less. You can figure out right-sided pressures. You can figure out left-sided pressures with tissue Dopplers. You can see if they have a degree of diastolic function, see if they have any valvulopathies. And I think with enrollment of VEXUS, we'll have a great idea about what that shows. The problem with VEXUS, there's been some publications that's come out in the last couple of months that shows, fluid tolerance is not the same thing as fluid responsiveness. And what's really interesting is that some people may be fluid responsive, but would be not fluid tolerant. So I think this field is just growing dynamically. And I think so far, there are those certain clinical parameters that you can use, CVP for right-sided pressures, and then using pulse pressure variation and cap refill for sure. With ultrasound, you can use the echo parameters. Then we'll see what the next few months and years bring. I think we'll have a lot more information soon.
Yeah, I agree. And then probably the third webinar, when we talk about de-escalation, will give us more hints and tips on how to stop fluid resuscitation, because we have to remember that the total amount of fluids that we give for resuscitation is about 6% during the stay of the ICU patient. So most of the fluids are given for maintenance, replacement, nutritional fluids, and fluid creep, which is 33%. It's little bags that we use of saline to dilute other drugs like antibiotics in. So I think after, and you also mentioned that after fluid challenge, the beneficial effect fades away after 30 minutes, and you lose your increase in stroke volume and pressure. So I would say that as we are moving from resuscitation to optimization, and the next webinar will be on de-escalation, maybe evacuation, we are shifting from fluid responsiveness, looking at that, towards fluid tolerance and maybe fluid unresponsiveness to avoid fluid accumulation syndrome at the very end. I don't know about the timing. I'm looking to Amr. We are 10 past 8. There are many more questions, but it will take too long to answer them all. I think we addressed much of the issues raised. So I would like to thank everyone and hand over to Amr. Maybe you, yes, you can.
Thank you so much, Manu, Armand, Samir, Fayez, and Ashraf, and all the attendees today. It's a great discussion. And what we are really try to advocate is we try to avoid one-way directional education just by giving a lecture. We are trying to help you to at least adopt these clinical practice guidelines in your practice. This is the way that you can have better retention rate. We also try to open the discussion for more time, so demonstration, discussion, practice doing, and teaching have the best retention rate in the learning pyramids. Just try to conclude with some take-home messages here. I want to leave you with. So I think the new guidelines, ESICM guidelines, suggest administering 30 ml per kg of IV crystalloids, not colloids, in the initial phase when hemodynamic monitoring is not yet available. And we couldn't emphasize more in presence of Dr. Ashraf about, the early adoption of the BOCUS in our clinical practice. So first 3 hours, yes, give 30 ml per kg crystalloids, and then adjust after this based on the clinical context and frequent assessment. The answer for question 2 regarding the liberal or restrictive strategies in the optimization phase in patients with septic shocks, they said they cannot recommend for or against systematic restrictive or liberal fluid administration. And question number 3 about the individualized approach in the optimization phase of septic shock, the recommendation or actually the suggestion was to use the individualized approach compared with the non-individualized approach during optimization phase. What about hemorrhagic shock? Again, as Armand said, there is different kinds of hemorrhagic shock that traumatic or non-traumatic. And if it is traumatic, is it penetrating trauma or blunt trauma? And they said the restrictive fluid resuscitation strategy as a part of permissive hypotension approach should be adopted, and fluid administration should be guided again by the hemodynamic and biochemical parameters. For patients with obstructive shock, including pulmonary embolism, they said clinicians should be using a cautious approach about administering fluid and should base their decision on the measured surrogate marker of right heart congestion. Again, another example of the obstructive shock with the cardiac tamponade, they said fluid should be given cautiously as temporary measure until definitive management can be taken. What about patients with left-sided heart failure, acute decompensated heart failure, and cardiogenic shock? They ungraded the best practice statement that fluid resuscitation should not be the primary treatment, so we shouldn't be very strict about that. The last one was about the ARDS should be restrictive or liberal. Again, they cannot make a recommendation about the volume of fluid administration. Again, they de-escalated the level of evidence, and this is actually very interesting because we should be able, or at least we thought at the beginning, with accumulating more evidence, we have better studies, we can be more certain about our practice. But what you're seeing here is when we dig deeper, when we get more knowledge, probably we go, the level of confidence goes down. And even the most, experienced people in the field, they still have less confidence compared to those with very little information. So bottom line is we need more information. We have given of information just a few. So what we are ignoring is much more than what we understand. And with that, I thank everyone for his or her contribution today. And I'm very happy to also organize with Dr. Manu in the future. The third part after the publication will come out about the de-escalation phase. I don't know when, but in the future, we should be able to do it. Collaboration is very important, and teamwork makes dream work. Thank you so much, everyone, and we'll see you on the just housekeeping stuff. We have your email address, we have your cell phone number when you register to this webinar, so we'll be in touch. We'll send you the recorded video of this webinar either tomorrow or day after tomorrow, whenever it will be ready. And if you have any question for us, please feel free to reach out. Thank you.
Exactly. Remember, fluids are drugs. So it's all about
Agreed.
giving the
Fluid stewardship.
right dose for the right indication, the right patient duration at the right time. Probably something like that.
Yes, sir.
For
Thank
joining.
you so much.
See you next time. Bye-bye.
Thank you very
Bye.
much, everyone. Have a good day. Bye-bye.
Bye.
Bye-bye.